to look at what we can get. None of these participants had any musculoskeletal impairments. After necessary approval, with full informed consent of the participants, we got them into the lab and we used the marker set, which is reported within Ryan Chang in 2014. And we let the participants to walk in an inclined surface on a preferred speed, and we tried to match that speed. Rather, we asked them to walk in the lab surface, in the level surface, and then we tried to match that in the inclined surface in the lab. Now, before I present the results, again, just to highlight the methodology, in terms of relative angle, the relative angle is the relative movement between the two segments. Here, it's the movement in this particular graph. It's the angle between the medial forefoot and the rear foot. Now, you could see that in the graph, it starts from 2 degrees and it goes down. Now, based on this relative angle as I've shown in that particular picture, we don't know what is the contribution of the medial forefoot and what's the contribution of the rear foot. We have seen several presentations, we've seen several papers. We always report relative angle, but we don't know what the contribution of those individual segments are. If we can understand those individual segmental contributions, it makes our life easy in terms of clinical management or in terms of product development. And we tend to ignore that fact that we tend to look at relative angle all the time. So the idea, again, just to reiterate the point, that's the relative angle that we look at. There are some other people who have reported segmental angles. If you look at the segmental angle, if you look at the medial forefoot to the lab coordinate system, you have the top curve there. And if you look at the rear foot to the lab coordinate system, you have the curve below. And if you combine those three, you have the rear foot in that particular graph in black, and the medial forefoot in blue, and the relative movement in red. Think of a different scenario. We always look at this red curve and we report our results to that. If you think of, in this particular scenario, the medial forefoot contributes more to the relative movement than the rear foot. It could be a situation where it could be a different shoe, it could be an inclined surface, it could be a device introduced within the shoe, which would change in a way that the rear foot changes the graph, but we won't see that, and the relative movement is going to be the same. So it's important that we look at the contributions from the segments. So, and again, it's important to look at that interaction between segments over time. So what we are trying to do here is phase coordination and using vector coding. Again, just to explain what we have done, in terms of, again, our work, we started this work and we started presenting results this way, mainly between lumbar spine and pelvis. We have now moved on to other parameters within kinematic human body. Now, what I'm trying to get at is we always report the distal segment on the vertical axis and the proximal segment on the horizontal axis. So once you have that, if you have in phase, which is positive x and positive y, again you have in phase movement if it is negative x and negative y, and you have anti-phase movement opposite direction if it is positive x and negative y. Similarly, anti-phase if it is negative x and positive y. Now, some of these concepts we have explained in that paper which I referenced above. In terms of segmental dominancy, as opposed to phase coordination, is if you look at the vector plots, again I've simplified it so that you would get the idea of what I'm getting at when you look at the graph in the next slide. Now, here there's a pure distal dominance. Here there is again a pure distal dominance, but in the opposite direction. Here you have a proximal dominance in that polar plot when you look at the plot, when you look at the results when we present it. And here it's again a proximal dominancy and very little distal dominancy. And each of those bins is, each of those quadrants is 100 degrees. So what we're looking at is they're quantified as a percentage contribution to the relative movement in time. So when you look at it from the result from this study, so if I look at 268 degrees in, for example, you could see the grade, it's a distal dominancy of 98% when I do the polar plot. Similarly, when I look at, say for example, 40 degrees, it has it's in that bin of in-phase proximal dominancy with a proximal dominancy of 55%. So that gives you an idea of which segment contributes more to that. Now, coming back to the results of this particular study, what we've done and what we've shown is this is the mean relative angle between both incline and level surfaces. As you could see, both of them are similar, apart from there is a slight shift. There is a slight change in magnitude too, but that's because of the marker set. It's the slight changes in marker set that we've used. However, if you look at the plots, as I've explained earlier, there are clear differences, which I'm going to go through in a minute. When it's walking on a level surface, the results indicate that there is a clear in phase with 4-foot dominant pattern. So you can see here, most of those are in that area. And again, there is a pattern in terms of level walking. As opposed to, when walking in an incline, there is still a 4-foot dominance, but there is a change in coordination pattern. So still, you can see there is quite a bit of 4-foot dominance, but there are changes in the pattern itself. What we're trying to do is show that between incline and level, although your relative angles might look the same, but there is clear differences in terms of contribution from various parts of the foot. Again, you could see there are quite a lot of anti-phase activity. So, I think the message that I want to give here is there's quite a bit of a complex multi-segment foot kinematics, both in level and in inclined surfaces, but we tend to ignore many of them because we are reporting relative angles. So I think if we look at these type of coordination patterns, we'd have much better idea and it will enhance our understanding to inform any type of footwear designs, orthotic designs, or in my case, many times it's designing clinical management. Thank you.
The paper is open for questions.
Nachi, that was a wonderful talk, and it is so complicated. My question is very practical. When we're looking at surgical outcomes and detailed results, multi-segment foot kinematics, fantastic, in a barefoot sentence. Any thoughts on how we might ever do this with a shoe on?
The approach is going to be exactly the same. It depends on how we modify the marker set. What I'm trying to get at is the technique and how we define the segments. Once you have an idea of how you want to define the segments, we could then identify which segment contributes more, which then gives us a good idea of how to intervene either clinically or by designing devices.
I meant if we wanted to understand the foot's true motion in the shoe, are we going to be carving up the rear foot and the midfoot and the forefoot of the shoe so that it looks like Swiss cheese when we're done? But then we can study multi-segment foot kinematics. I meant that kind of practicality.
But that's a practicality. But the other thing that I always say is there are so many new wearable sensors. So if we can use, rather than using marked set, if we can use other sensors to define those segments and get the data from the segments, we can use the same approach to get the same results. That's what we do.
Thank you. The method looks very sophisticated, very interesting, but I'm curious to know that it seems to me that the segments that you're examining are potentially artificial constructs. They're dependent upon your marker configuration. Have you examined to see how these phase changes, how sensitive they are to different marker configurations?
Yes, we have, and we have used several mark sets, and as I said to Howard, we are also trying to do with various other sensors at the moment. So it's quite a broad range of work within our lab. You could see some of the stuff in those two papers that we've already published. There is one coming out. So yeah, we do have, but there is quite a consistent. Once we understand the approach, the results are quite consistent. I think what you're trying to say is if we define the segments in a different way, are the results going to be different? Is that the question?
Yes.
Yeah. As long as we have the same anatomical area, it looks the same and the results are the same. We could definitely be looking at the fine and pelvic coordination.
Thank you.
Thank you.
Okay, so the next presentation is by Kota Ito, and he will talk about three-dimensional measurement of the human cadaver foot-bone kinematics under axial loading condition using biplane X-ray fluoroscopy.
Good morning. My name is Kota Ito from Keio University, Japan. Today, I'd like to talk about our cadaver experiment. The title is Three-Dimensional Measurement of the Human Cadaver Foot-bone Kinematics and Axial Loading Condition using biplane X-ray fluoroscopy. So, what we'd like to know is the foot function of the human foot. The human foot is thought to be more functionally adapted for generation of stable and efficient bipedal walking. If we compare the foot structure of the human and chimpanzee, we can observe some characteristic anatomical structure in the human foot structure. For example, human foot has a big toe aligned with other toes. So therefore, we can make effective progressive hold at the distance point. And human foot has arch structure and large heel for the heel contact. So if we focus on the human foot structure, we can observe some characteristic anatomical structure. However, the functional adaptation of the human foot remain unclear. For this purpose, many previous studies conducted the 3D measurement of the foot bones during walking. For example, bone pin study, and recently X-ray fluoroscopy and model-based motion methods have been conducted. And due to these efforts, how the foot bones move during walking is becoming clear. However, foot bone movement during walking was generated by extrinsic and intrinsic muscle force and ground reaction force. So it is difficult to infer the innate mobility of the human foot, and it is also difficult to understand how the morphology is adapted to bipedal walking. So in this study, we aim to measure the 3D kinematics of the cadaver foot bones and axial loading. If we use a cadaver foot, we can control such loading condition. This is our experiment setup. For 3D measurement, we use biplane X-ray microscopy system. It consists of 2 sets of X-ray probes and blood panels. So if we put the specimen in the system, we can obtain biplane X-ray microscopy at the same time. In this study, 5 cadaver specimens were actually loaded up to 600 newtons. And we captured the X-ray image before loading and after loading. And the mass force was not applied in order to observe pure bony motion of the human foot. And 3D motion of 10-foot bones were measured via model-based illustration method. Here is the X-ray image, and here is a matching result. We matched the 3D bones of the 4 tarsal bones and the 5 metatarsal bones and tibia to the X-ray images. And this is the matching results of the before loading and after loading. And we also confirm the errors of matching were sufficiently small. And in order to describe the movement of bones, we quantify the bone translation. Briefly, translation of the centroid of the corresponding bone due to actual loading was quantified. This is the result of the bone translation in the medial-lateral direction. The horizontal axis is force and the vertical axis is translation. And left is a tarsal bone result, and right one is the metatarsal bone result. All bones were translated medially due to axial loading, especially the medial translation was larger in the tarsus and navicular. Next, we also quantify the bone rotation. In order to describe the bone rotation, local coordinate system was defined at the neutral posture. The XYZ axis of the local coordinate system were aligned with the world coordinate system at the neutral posture. Then YXZ Euler angles were used to describe the changes of orientation of bones with increasing axial loading. Here is the result of the bone rotation in frontal plane. We can observe the calcaneus was rotated in the everting direction with increasing axial loading. In transverse plane, in the rear foot, the calcaneus, tarsus, and tibia were rotated in the adapting direction, also internal rotation. So in this study, first we can observe the tibial calcaneal coupling motion under the axial loading. This is a coupling motion of the calcaneal eversion and internal tibial rotation. Many previous studies have been reported about that. However, in this study, we can describe the mechanism of the tibial calcaneal coupling. First, calcaneus was everted due to axial loading. Then tarsus stripped down the tilted subtalar articular surface of the calcaneus. So tarsus is medial-inferiorly translated and adapted. Then tibia was rotated in the direction of internal rotation. So the detailed kinematic mechanism of the tibial calcaneus is quantitatively described. However, what is the more functional meaning of this coupling motion? So let's go back to the bone rotation results in the transverse plane. In the rear foot, the calcaneus, tarsus, and tibia were rotated in the adapting direction. On the other hand, the navicular and metatarsal were rotated in the adapting direction. So I would like to discuss about this characteristic bone movement. First, the tarsus is medial-inferiorly translated and adapted due to eversion of the calcaneus. So the collar head moved medially. Then the compressive force between the color head and navicular was applied more medially. Therefore, the navicular and metatarsal were positively adapted. We hypothesize that the human foot may generate medial rotation moment under the axial loading by the such characteristic bone movement. The moment around the vertical axis is applied to the human body during walking. So the vertical moment generating mechanism embedded in the human foot structure may contribute to cancellation of this free vertical moment during walking. Also, generation of the efficient and stable bipedal walking. I would like to conclude my talk. We investigated the innate mobility of the human foot based on a cadaver experiment. And the characteristic movement of the pulse may contribute to the moment generation capacity of the human foot. Such detailed description of the human foot deformation of the human foot structure is useful to the ergonomics and healthcare. But one of our future work is we are going to try the comparative analysis with 3D kinematics of 8 foot. If we compare the 3D bone movement of the human foot and 8 foot, it will be helpful for clarifying the functional adaptation of the human foot. Thank you for your attention.
This paper is now open for questions.
Hi, Philip Jamal, University of Denmark. Did you try other types of loadings, like loading directions? And if so, did it alter the relative movements between the segments?
Sorry, one please.
Did you try other loadings? You did actual loading, but did you try other loading directions?
Now we are trying, but we have not get the results, not yet.
Do you have an idea if that would change the rotations?
Yeah. Actually, in this study, we just tried axial loading, but now I'm going to try to make a different posture of the tibia. So we made a we made another setting for the change the different posture of the tibia. Now I'm trying.
Thank you. You kind of answered my question in the last talk, which is stereoradiography would be, or bilateral would be a technique you could potentially look at a shoe on a foot. And I'm just wondering if you ever did it and what did you find?
Okay, yeah. I think if we made some shoe for the human foot, firstly we have to understand about how human foot actually deform, and with the interaction with the floor. And so first I would like to know about the detailed deformation of the human foot. Then, and I also propose such methodology for the measure the detailed human foot deformation. So after that, I would like to replicate the realistic conditions like with muscle tendon and with shoe on the cadaver foot. And yeah, it is just beginning, but this methodology may serve as an effective tool for the ergonomics. Yeah, I believe.
And one quick question.
Yeah.
I noticed there was no cuneiforms, and maybe it's because of my lack of knowledge about primate anatomy, but if there are cuneiforms in the specimens you were studying,
yeah,
you could also build coordinate systems.
Yeah, I'm going on the cuneiform, but it is difficult to match to the X-ray images because they are very small, tiny bone, and there is main overlap, so it is difficult to match for model. Thank you so much.
Thank you very much. That's a very nice piece of work. I have a question though. We're still kind of using terms like abduction, adduction, and these planar reductions of motion. And one of the things about connectivity is it depends on your perspective. If you're from the perspective of the foot, it's all happening in the tibia. From the perspective of the tibia, it's all happening in the foot. Shouldn't we be moving to a different representation of motion in terms of quaternions or axis angle, or defining the axis of rotation, and rather than trying to, rather than describing it in terms of these arbitrary planar components?
Sorry, one more please.
Sorry, we still talk a lot about internal, external rotation, abduction, adduction, and these things, these artificially imposed reference frames.
Okay, yeah.
Don't you think we should be talking about where is the axis of rotation in 3 dimensions, and what is the velocity, what is the amount of rotation around there instead?
Yeah, absolutely. Yeah, it's one of the limitations of this research. I have a 3D movement of the 3D movement data of each form model, so I can combine another coordinate system, or I can define the axis of rotation.
Quaternion rotation or something. The axis will move, and I think that will, you may be able then to be able to see how these different elements coordinate, and not just as opposed to describing this different. I think the description you have is fantastic, but rather than describing as separate pieces, you might have one integrated.
Yeah, thank you for your advice. I will try to do that.
Yeah, thank you very much.
Thank you.
Okay, let's move on to the next section. Thank you. Our third talk is the available and proposed performance measures in terms of the reliability, validity, and applicability of another population of systematic review by workers.
Alright, so for orthotics that effectively manage malalignment, reliable and accurate measurements are necessary. So podiatry foot biomechanics currently utilise a method introduced by Root and his colleagues in 1971, which assesses the level of deformity against an idle position. This idle position is known as the neutral Kaplan stance position. It is compared to resting so that abnormalities can be determined. However, the neutral stance position requires the subtalar joint to be placed in neutral, and this is a theoretical and subjective position, and this is because it is classified when the joint is neither pronated nor supinated. As a consequence, alternative and improved techniques have been proposed by the literature to address these implications posed on clinical and research practice. So these have included such as the navicular drop test and navicular drift test, which was proposed by Brody in 1982 and Metz in 1998, and assess the sagittal and transverse plane motion of the navicular in a neutral position in comparison to a resting. There's also the foot mobility magnitude, which was proposed by McPoyle in 2008-2009, which measures dorsal arch height and mid-foot width in a non-weight bearing position in comparison to a resting. So with the literature proposing numerous techniques which are accessible to clinicians, there's a potential to confront the root paradigm and provide a reliable and validated alternative. So the purpose of our study was to critically appraise the available literature pertaining to the reliability and validity of foot measures that quantify or describe foot pronation or mobility, and determine if they are clinical or research appropriate tools. So our search strategy involved looking at adult humans with the intervention of foot measures and an outcome of the reliability, validity and applicability of those foot measures. So the databases that we searched are shown, and our search terms that we use and their mesh headings, and we searched the data up until the 15th of January 2016. So our inclusion criteria involved those that were quantitative, and full text was available, we were looking at the reliability and validity of foot measures that were looking at pronation only and were distal to the subtalar talocrural joint. We wanted static measures that were clinically applicable and relevant, and we wanted human adults and articles that were published in English. We excluded those that were qualitative and full text was unavailable. We didn't want anything that's looking at cause and effect, and assessments that were conducted superior to the talocrural or were looking at the digits. Dynamic, radiological and force or pressure assessments were also excluded. To critically appraise the literature and assess the risk of bias, we used the clinical instruments reliability and validity critical appraisal tool, and answers were weighted 1 for yes and 0 for no or not applicable, and those that were had a score greater than 7 were included in the synthesis. So looking at our study selection, the data identified 3,324 articles, and by using our eligibility criteria and the critical appraisal tool, we were able to include 55 articles into our synthesis. So looking at our study characteristics, those that provided an age range, which was 51 articles, we had a mean age of 31.13 years and an age range of 14.1 to 85.1 years of age. The majority of the population were asymptomatic or healthy adults, but there was other populations which were included and are listed. Majority of the articles were published between the years 2000 and 2008 with a range from 1987 to 2014. When we looked at our assessments, we were able to identify 6 clear categories that we could classify them into, and there was 44 different assessments within those categories. So this table is sort of a really brief summary of the sort of statistics that we were finding. And if you look at the root paradigm, the reliability is quite variable and so is the validity. The Brody paradigm slightly improves on top of this root paradigm in terms of its reliability and its validity. And the Redmond paradigm provides adequate reliability and validity. The McPoyle paradigm again improves on top of the root paradigm in terms of reliability with the one outlier of the 0.4, but this was only for one measure and all the others were above 0.73, and it has validity for one of its measures. Footprint-based measures also provided adequate reliability and validity. The others category was measures that didn't really belong to the other 5 categories, and this only involved 4 different measures. They also had sort of adequate reliability, but the validity was only for one measure, and that was for the longitudinal arch angle. So what we sort of found was that the majority did provide values for their reliability, but less than half of the studies actually included investigations on the measure's validity. And this was kind of a concern of ours because as the reliability is important of a measure, the validity is just as important, so that when we're using that measure, we know that it's actually assessing what it proclaims to. And obviously with this systematic review, there are limitations, and that looks into the application of our critical appraisal tool was actually sometimes difficult to apply to the articles that we were including, and therefore there's a potential that we have had relevant research excluded. A lot of the studies in the way that they actually conduct their assessments use different methodologies in the way that they did it, and this could be either in the positioning that they're using, so the amount of weight bearing they're having, or the apparatus that they're actually using and the experience of their examiners. And also looking at the collation of all that statistics is a lot of the studies also use different approaches in the way that they statistically analyse their results, but we still collated them all just because we assume that the results have similar implications, and that future studies should focus on more succinct and reproducible protocols. So in conclusion, all the 6 categories have a range of reliability and validity. When looking at the Root and Brody paradigm, it contains questionable reliability and validity, and the McPoyle measurements are reliable and have partially validated measures. So we've grouped these together because these compare an ideal to a resting, and this provides a goal for the clinician to aim their treatment towards. When we look at the Redmond and the footprint-based measures, they are reliable and they are validated, but they're classifying the foot at one point in time, So this makes it difficult for the clinician to use in terms of their treatment. But it is quite useful in understanding the foot posture and for research to be able to classify it and put into different cohorts. The others category, as it only had, I think, 3 articles included, we've determined that it actually requires further research to understand its clinical applicability. So as in the poster that I presented yesterday, it all sort of led to the question can this non-weight bearing position used by a big coil in the foot mobility magnitude be used as an ideal in comparison and as an alternative to the neutral stance position utilised in the root paradigm? Thank you.
Okay, there is open for questions.
Alex, you always have questions.
It's interesting and important, and I appreciate how hard it is for validation papers to be done, because what would be an order of magnitude more accurate than what it is you're trying to validate. And in the area of foot and ankle, that's a very difficult thing to do compared to reliability. But you mentioned something earlier in the talk, which I just wanted to bring back up, the concept of neutral position, whether it's a tailor neutral or a calcaneal stance or something. And I don't really stock in any of those methods. I don't really care which one's more reliable. I just want to use the most reliable way to report data. And in particular, think about multi-segment foot kinematic data, where we have to have an X and a Y axis. And we have to know where 0 is on that Y axis so that we can accurately report where these angular excursions are occurring from. So if it's not going to be that fictitious neutral definition, do you feel that one of the other methods provides us a definition of neutral that is rigorous enough that I can hang my hat and say that's a 0 when I'm reporting motion between the rear foot and midfoot or midfoot?
I'm not 100% sure if I can come from a good answer from that, because I'm still more looking at it clinically, and that whole kinematic sort of side of things is sort of out of my realm of knowledge, so I don't know if I could give an exact answer to that. Sorry.
Thank you.
So we move to the next presentation, and we have Sophie DeVries, and she will talk about foot kinematics in the hypermobility type of Ehlers-Danlos syndrome using again foot model.
In the Ehlers-Danlos syndrome, and I'm more specific in the hypermobile type. Now, I don't know how many of you are familiar with Ehlers-Danlos syndrome, because it's a heterogeneous group of inherited connective tissue disorders. It's not such a big group of patients. It's said to be less than 1 in 10,000, and unfortunately, females seem to have it more often than males. Now, within that bigger group of the Ehlers-Danlos syndrome, there's the hypermobile type, which is the most common and the biggest group in there, the most common subtype. And their distinct parameters are the mild skin involvement, so the skin is really hyperelastic, they can take it and kind of lift it almost from the body, which is one issue they have. But a more profound problem is a severe generalized joint hypermobility, really leading to dislocations when they move, in combination with chronic joint and limb pain. And studies have shown that there is a significant part of musculoskeletal problems located in the lower extremity. And when we questioned them, about 80% of the patients said you have ankle and foot pain. Now, we do see a lot of foot anomalies about foot deformation, hallux valgus, and lower arch, and so being examples of them. That in combination with the ligament laxity, in combination with the joint and muscle pain that's present in the lower limb, and it's been shown in other research that they have difficulties with transmitting the muscle force, especially around the foot and ankle and lower limb. That all together leads to insufficient functioning of the ankle-foot complex, which will affect gait, and if gait's affected, they tend to walk less, and reducing general mobility of the patients. And if you reduce their general mobility, that's a very debilitating factor that might really compromise the quality of life. So therefore, to us, important to look into. Now, if we really look at gait, the studies about gait are actually very limited. There's a group in Italy who's been done some work, and we've done some previous work looking at the temporospatial parameters with the gait ride. Now, what we know from the literature and our own work, which is out there, is that they do step with a reduced gait velocity as well, as well as reduced step and stride length. We have seen that there's some altered kinematics on the pelvis, hip, knee, and ankle. But when it comes down to the foot kinematics, we really don't know what's going on. It's poorly understood, mainly because the other group in Italy used single segments for the foot mobility, which doesn't give much details about what's really going on there. So a better insight is really needed in that foot and what's going on, trying in the future to set up some evidence-based therapy guidelines to help those patients. So the goal of this study was trying to get a better insight in the foot kinematics of the hypermobile ADS patients using a more segmented foot model. So we used, or we included 23 female hypermobility type ADS patients. They were diagnosed according to the Villefranche criteria. Earlier on in this year, there was a new set of criteria established and come out, but we included them before. Now, if we look at them, they still fulfill the new criteria. Now, one parameter of the Villefranche criteria is the Biden scale, and I'm not sure if you are aware of that, but that's really looking at the prolixity of the joints. And if they fulfill 4 out of the 5 criteria, they have already fulfilled one of the 5 major criteria to be diagnosed with it. Now, other parameters we wanted them, of course, to be able to walk barefoot and at least 5 meters. We didn't want them to have any injuries or lower extremity problems at the time of the gait analysis, and not in the 6 months before. We excluded the ones that had comorbidities or co-pathologies that would influence the potential, or would have the potential to influence the gait or speed. And we matched them with 23 female healthy controls. They were matched for age and a few exclusion criteria, of course. As said, we used the Ghent foot model, which allows us to look at 6 segments. We have the lower leg, we have the rear foot, we have the midfoot, the medial and lateral forefoot, and the hallux. Data collection was done with a standard setup for gait analysis. We had the camera system, we had the pressure platform on top of the force platform. We used the mid-gait protocol, and we asked them to walk with a self-symmetric comfortable walking speed. As far as statistics, we looked at discrete points. This is just more insight. So we looked at discrete points in the curves and used linear mixed models to see if there was any statistical differences. Now this brings us then to the methods, to the results, excuse me. And I presented them, sorry Martin's still in the 3 planes that were defined or that we're used to handle in clinical settings. There's the sagittal plane in the first one, there's the frontal plane in the middle, and there's a transverse plane on the other side. The dotted lines are the patients, the full lines are the controls. And I present the stance phase, and within the stance phase you see a division of different parts of the stance phase, and it was on the separation of the different parts we took the time points to calculate. Now the time points are not chosen randomly, but are based on work which is published by Annelien Cochrane in the previous years, and there the phasing or the partition of the stance phase is based on pressure measurements, where you really can pinpoint the time based on those measurements. So we did that with each individual and took their own timing within their gait cycle to get the same moments to be compared. Now, as you can see for the rear foot, the asterisk is above mark that we found some significant differences. and we will see through the different segments that they vary between planes and between time instance where we did find differences. Here you see in the sagittal plane that the differences are fairly large. When you look at here the statistical difference on the initial foot contact, it's a very small difference. And if we move on to the other segments, as you can see, they vary. Like for instance, in the midfoot, we don't see anything in the frontal plane, but we do see differences in the transverse plane, and the time instance where those differences occur differ between one another. Same for the other parts of the foot. Now, we do find some significant differences. It's difficult to compare with literature which is out there from the Italian group, because as I said, they used the one segment foot model, which doesn't mean exactly looking at the same motion in the, they call it the ankle and we call it the foot. Some of the differences are very small, we found. And what we have to do from now, because this was the first attempt to get a grasp on what's going on in the foot of those patients, is that we have to relate that. We do think they are related to the clinical manifestations of those patients, but are they really an expression of what we see in the clinic we see with them? And much more important is we have to determine the impact on foot function and the clinical relevance, because it's nice on one side to find statistical differences, but if we're only talking about a few degrees, are those degrees really clinical relevant, or is that just variation amongst the population? To get there, we will have to look at more subjects, of course, and I do think it's been mentioned here before, this is indeed again a barefoot study in a lab, so quite far from reality, so we'll have to check if what we see in the lab in barefoot walking also applies to daily life and reality where they're walking outside in shoes. Now, if we get some more information and data, what we do hope is to establish some evidence-based therapy guidelines, because now those patients are provided with shoes, braces, orthosis, insoles, to the best of everybody's knowledge, of everybody's trying to help them to the best experience they had. But we see that half of the patients are doing well with what they're provided, and the other half of the patients is still suffering a lot of pain and problems, and ending up in a disabling situation where they cannot walk, and it's really compromising their quality of life. And in the end, that's what you want to reach with patients. You want to make them happy, you want to keep them walking, and you want to offer them a higher quality of life despite the disease or the pathology which is there, which you cannot take away. So thanks for listening, and I'm happy to answer questions you might have.
Thank you. This paper is now open for questions.
Oliver Morgan, Anglia Ruskin University. Really interesting talk. I was just more wondering about the motion of the medial forefoot. When you were talking about clinical relevance, obviously, there are certain situations like hallux valgus, which some people are relating to hypermobility. Others have theorized about how it's rigidus maybe being associated with it. I was just wondering whether within the subset of the Ehlers-Danlos patients, whether you see any different motions between the medial forefoot and maybe the midfoot, and whether you think this is related to the two disorders.
Well, in that group of patients, we hardly find any rigid things, so it's all going to be mobile, and collapsed arches is something we quite often see just because the ligaments are that stretched and weak and lax, they cannot support the arch structure enough. So have we seen that? I guess the ones we had were really all to the very mobile type, and I would have to look at other patients groups where we would expect more rigid foots to really make that comparison. I think within the group it would be difficult to find that.
Our final talk today is the adjustable medial longitudinal arch height foot orthosis and the biomechanic significance by
Morning. I'm Oh Hai Hua from University of Michigan and Shanghai Jiao Tong University Joint Institute. I know it's the known name. It's in Shanghai. Today my topic is adjustable medial longitudinal arch high foot orthosis and biomechanical significance. As we know, the foot arch related diseases and injuries are common. One example is like plantar fasciitis, where in your plantar fascia you have some flame inside, and so when you walk, you feel painful. It happens a lot in the elderly or military men. So one way to treat them, there are several ways to treat them, like just rest or surgery. So one intermediate way is to use arch support orthosis. Presumably, it can decrease the pH strain. So I'm just going to talk about how typically the arch support orthosis is made. So typically first, the doctors will put your foot into a position. It's called a subtalar joint neutral position. It's either non-weight bearing or weight bearing. And then you try to get the surface information from it, either from plaster cast or foam impression box to get a negative impression to serve as a mold. Or more recent technique by contact pins and 3D scanning to get some digital information of the surface. So then using this surface information, you can either create the orthosis by vacuum forming through thermal plastic or CNC milling. However, people found that the repeatability of orthosis prescription is not high. So we try to analyze why it's not high. There are several errors in each step. First is in the foot positioning. There's various methods for determining the subtalar neutral joint position, and this may create an error up to 3 degrees of deviation. And usually plus minus 5 degrees of the pathological type of roots is like 5 degrees. So the error, I think, is too much. And also there's error in the surface information extraction. One research by Lofton, he found out that the arch heights of 4 of the negative impressions they are using for creating the orthosis can vary up to 2 centimeters. And of course, there's also error in fabrication. And this accumulated error, they will result in orthosis which varies in construction and its function, like foot plantar pressure redistribution. So the next question I want to ask is the error going to be a problem? So to answer this problem, we first we want to try to see what is the effective orthosis height range. If the error is smaller than this range, maybe it is okay. If it is much larger, then it is not acceptable. So to say it is effective, in our case, it's like it provides arch support and it is comfortable. So as we increases the arch height from flat to some height, before touching your foot arch, it is like no effect. So after it kind of touches your foot arch, and compress, the pressure in your medial midfoot starts to increase. And as it compresses more, it starts to increase to a point that your arch starts to feel pain. So the effective range is like between this green line when you start to feel when the pressure starts to change significantly. to the point that you start to feel pain. So our hypothesis is that the effective orthosis height range is smaller than the arch height variation from the prescription errors. So what we did is we tried to control the variables as much as possible. So instead of using insoles provided by manufacturers, we try to fabricate our own insole, develop our own insole. So our prototype is here. If you are interested, you can come to me after the meeting. So essentially, it is our surface can change its height. Can change its height from 21 to 36 mm. And it is made of a 1 mm thick semi-rigid fiberglass, like this green one. And we have made a medial longitudinal cutout to relieve the degree of freedom. So we put in a lead screw in here, so when the lead screw travels front and back, it kind of pushes the arch to higher and lower configuration. So we also put a truss structure here to maintain the form, maintain the shape of the arch. And we put it in a sandal with the post to hold it. And we use this as the test shoe. So we take 6 healthy male subjects and we ask them to walk with self-selected speeds, and we measure the plantar pressure distribution during their gait with Novell pedal, and then we increases the arch height at a 1.5 mm interval until the subject starts to feel discomfort. So there's a few terminology to help us to understand the range of effective orthosis height. So we start with orthosis arch height initial. This is like the initial orthosis arch height. It basically explains itself. So we increases the arch height until significant mean peak pressure changes, and we use one-way ANOVA to find out this point. We keep increasing the arch height until the subject feels pain. And the range is determined by the difference of these two heights. So this is the result of one of the subjects. As we can see, it is kind of as the arch height increases, it kind of keeps the same constant values in the medial midfoot. And so what we are assuming is that the arch orthosis starts to feel the space between the arch first, and it will compress, so the medial mean maximum pressure has a significant change. And as it increases, it overcompression, so you start to feel pain. And if we combine all the results from the 6 subjects, we found out that the mean orthosis arch height range is like 4 mm. It's much smaller than the fabrication error. So we would say that the superior neutral joint positioning and the measurement is not reliably repeatable because maybe for one of these reasons. Because it's like a static foot positioning, but when we are walking, it's like a dynamic scenario. And also, the methods to determine this position is not repeatable. So instead of using this paradigm, we just propose that maybe there are other paradigms or other foot positioning methods we can use. So we can use, for example, like the adjustable arch height orthosis as a fitting tool, and then as a mold for fabrication. So instead of the traditional way, we can first fit the subject, the patient, with an arch adjustable height orthosis and do some dynamic testing to find out where is the effective range, and then we fabricate based on that shape. So there's a few limitations in this study. First is there's a small sample size, and the sample, they kind of lie in the same range. There's not many variation in the samples. And we just look at the mean maximum pressure in the medium midfoot. There are other parameters that should be looked at different designs, like pH strain or forefoot pressure reduction for different diseases. So to conclude is that we developed an adjustable height orthosis. We use this to find out that the effective range of orthosis is smaller than the prescription error. So we propose that the orthosis fitting may be helped by the adjustable height orthosis. Thank you.
One quick question on the floor. Okay. Now, why don't we just move out because we're behind the schedule. Thank you.
Okay, thank you.
So I know it's a coffee time, but before we move on, let me invite Howard to talk about the next iFAB.
Just while we're waiting for Howard to get this loaded, we are running about 20 minutes late, but we have plenty of time in the poster session, so we'll run still for a half-hour morning tea break. I think you all have done very, very well to survive this long. So we'll run a half hour, so we'll just start 20 minutes late for the next session.
Okay. This will just be a couple minutes. If I can have your attention. So I'm Howard Hellstrom, and I'm a scientist at Hospital for Special Surgery. And I have the joy of hosting the International Clinical Biomechanics meeting next April. It's going to be Sunday, April 8th through Wednesday, April 11th. We have already secured a venue, the Wyndham New Yorker Hotel. It has 1,400 rooms, so I don't think we're going to run out, no matter how many of you show up. Abstracts are due November 17th, and I have a couple of slides just to kind of show you some of the things about the talk, about the setup and philosophy of the meeting. We have a very nice program committee who is working hard, and we meet monthly to discuss program issues and tutorials and things of that nature. The philosophy is that we're going to have a problem-based meeting, so every session will be problem-based, and that means that you can have an epidemiology or experimental, clinical outcome, treatment mechanism, computational, or injury prevention paper all in the same session. So we are encouraging the podiatric physicians and physical therapists and foot ankle orthopedic surgeons, biomechanists, kinesiologists, and scientists to be in the room at the same time and talk to each other. And talk about the same topic. This is the venue. It's an Art Deco kind of place, the Wyndham New Yorker. It's across the street from Madison Square Garden and Penn Station. If you look straight up, you'll see the Empire State Building. And if you look down the road, you'll see Macy's. If you go 8 blocks north, you'll run into Times Square. So it's very well situated in Manhattan to have a lot of fun and enjoy and explore. As a typical room,
price, basically so that it wouldn't be too expensive, because it's so expensive to go to New York and stay in hotels. And they are going to include all long-distance and international phone calls, a business center, fitness center, and internet as part of the price. The meeting room looks like a whole room. So if anybody's getting married, you could throw that in here too while we're having a meeting. It's very beautiful. It has a balcony, and there's about 20,000 square feet of meeting space on 2 different floors. The first floor, that shows you the ballroom, and the crystal ballroom, which is where the vendors and posters will be, and there's plenty of space for vendors and posters, which should be fun. And then there's another floor above where there's smaller rooms as well as the balcony for the ballroom, and the smaller rooms are where the tutorials are going to be. So we have plenty of space. Things to do for fun. I grew up in New York City, so I'm a good person to ask. That all of the staff for the meeting of the local committee are wonderful people to ask for restaurant advice and whatnot. But let's say you like the park. Central Park is one of the largest parks in an urban setting, with running, jogging paths, lakes, baseball and soccer fields, and believe it or not, a Shakespearean theater. If you want to explore our Chinatown, it's quite large and a lot of fun to see. Great food. And if you like me and you grew up in the tail end of the hippie period, Greenwich Village is where Jimi Hendrix, Janis Joplin, and many great artists started their careers. And in modern times, so we'll throw Lady Gaga in there because she did go to NYU in the music school. And if you like rock or jazz, there's one of the great jazz places. I'll show you know. And if you have a more sophisticated taste and you want to see Philharmonic, Metropolitan Opera, or ballet, Lincoln Center. And we have hundreds of museums. In particular, growing up as a kid there, I was always fascinated with dinosaurs in the Natural History Museum, but there's probably about 50 different dinosaurs fully replicated. Times Square for the theater goers and nightlife. And lots of sports. We probably have 8 or 10 professional sports teams, so we pretty much have everything covered in that range too, if you're interested in that. And lots of landmarks as well, which may be fun visiting. So you might want to come a day or two earlier, or stay a day or two later, if you're going to bring family to show them around. So, with that said, I hope to see you all in New York City in April, and welcome you to iFAB 2018. Thank you.
원래 저도 많이 했어요. 저도 내가 나와서 밥을 해봤는데 근데 그게 수다자는 괜찮아요. 처음에는 되게 한번 하고 나니까 적중
皆さん特典を